So thanks again, everybody, for being here. Our plan tonight is to basically hear from some physicians, from some people with firsthand experience of the medical system of this country in a condition that we have come to call underinsurance. This can be somebody without insurance, as lots of people are, unfortunately, but also people that have insurance that is pretty full of holes, which I'm sure a lot of us have sort of run into in one way or another. The experience that you do have insurance, but maybe it doesn't cover the medication that you need or a test that you require, or you are basically forced to take suboptimal care in some manner or another because of the conditions of your insurance, what you pay for. So our panelists here, I'd love if they would first get some time to introduce themselves, talk about what they are doing now, where they're at in relation to NEOMED or to our organization, and then their relationship to kind of the underinsured experience we're talking about tonight. And then they'll each get a bit of time to talk about sort of a specific story or a specific testimony that they have about that. We'll spend the first 30-ish, 40 minutes doing that, hearing from our panelists, and then there'll be some time to talk at the end, a little bit of Q&A. We've got some questions prepared, and if any of you come up with anything you'd like to hear about or ask specifically for any of our panelists, feel free to send those questions in the chat, send them to me directly or to Sam, or post them generally, and we'll sort of moderate those as we go and have a little discussion about all this, and hopefully finish right around 7 o'clock so you guys can get back to dinner and whatever else you need to be doing tonight. So without more rambling from me, I'd love if you folks want to go ahead, maybe, I don't know if we should go maybe alphabetically. Dr. Barreiro, would you like to start?
Sure, my name's Tim Barreiro. I'm a pulmonary critical care and sleep physician. I'm in Youngstown, Ohio. I've been in clinical practice 20 years, so relatively probably a lot older than some of you guys. And I am currently the director of the Pulmonary Health and Research Center. The Pulmonary Health and Research Center, and how it relates to why it's important to you, was developed when I joined faculty at the hospital to be part of the internal medicine residency program in GME, which is about 8 years after I started my career. So put the numbers together, 12 years I've been doing that. The development of the Pulmonary Health and Research Center was to capture indigent and develop an area where patients who were disadvantaged, had low health income or literacy, to find a place within the hospital. What was happening at the time, and this will be part of my story, was some interesting things, the economics of healthcare in and of itself. And then what has happened is when patients who were admitted to the hospital and discharged and seen by a pulmonary critical care physician were not then given access to follow-up unless they would pay a fee prior to, because of low dismissal rates or inability. And from that, the mission is I joined faculty and came and developed the Pulmonary Health and Research Center, which I am currently continue to do thereof. So I am a graduate of Ohio University. I'm an osteopath in training. I did my pulmonary critical care fellowship at the University of Rochester, and my internal medicine at University of Pittsburgh. I am a NIH Health Minority Research Scholar, which I deal with the aspects of healthcare in Latino populations surrounding pulmonary disorders, mainly asthma, and is what I continue to do. So that's a little bit about me.
Thank you very much, Dr. Palmer, if you want to go ahead.
Awesome. Well, hello, everyone. My name is Aaron. I just go by Aaron. I'm a neurosurgery resident here in Chicago at Northwestern. I actually applied to NEOMED when I was applying, but I wasn't smart enough to get in. I went to medical school at down in Dayton, Ohio, Wright State University. Enjoyed my time there. And then I did a year of general surgery before ultimately switching to neurosurgery. So I'm 7 years out of medical school, 6 years in neurosurgery. I love it. Work lifestyle's not the greatest, but I love what I do. And I'm excited so I'm from Akron, and I'm excited I'm looking at jobs to come back to Northeast Ohio, actually currently. The to me now, I'm like surrounded by like high rises and mansions here on the Gold Coast. But growing up, we didn't really have a lot of money. Like my family, we had 7 of us, sometimes 8 of us. We lived in a 2-bedroom house. I lived with, I didn't take a shower until I graduated high school. I just had a tub, and I didn't think that was a weird thing. You know, the whole point of this is that, you know, earlier on when you're getting those well child visits and getting those vaccinations, you kind of stay on track. When those aren't required for school, if you don't have insurance, you don't have the means to, you start missing appointments. And so me and my brothers and my sisters, we never went to the doctor. I didn't even think about becoming a doctor until I was in undergrad, because I just never saw one. And some of the important things is my brother has really bad asthma. And I didn't even realize this till I was in medical school. He always just had difficulties breathing, and we just assumed that was just Adam. We didn't even think to take him to the hospital or to get, you know, get the care he needed. The other thing is that my older brother, Adam, same brother, he's legally blind. And we didn't know that until like I would walk with him to school, and he'd like, "Can you see that sign?" And I thought he was joking around, but he made some comments that he couldn't see the board before he went to high school, and that's when we found out he was blind before he went to high school. So I remember him getting contacts for the first time and being able to actually see like trees and leaves and stuff, and you know, that really you know, broke my mom, honestly. But it was little stuff like that all the while. You know, dental appointments are another big one. Dental care is innately tied to education and employment. And honestly, even being a physician now and a resident, not getting paid much, but I was just able to afford some of the dental procedures that I required even when I was a kid. You know, I remember, and we didn't have the greatest dental care. We could have had a little bit, you know, better dental hygiene. But I remember cracking my 2 back teeth when I was a teenager. And I remember I just like, sounds ridiculous now, but I used to just pop Tylenol and ibuprofen just anytime the pain, because it hurt so much. And eventually my mom saved up enough money for me to, you know, get 2 root canals, because it's, you know, how are we going to pay for, you know, $3 grand when we're making, you know, 20 grand all together, and that has to, you know, support an 8, you know, person family. So they saved the money, and I got 2 root canals. I got 2 root canals when I was 14 years old. And after that, like after they were, you know, removed the nerves, obviously I was supposed to go back and get crowns, but we couldn't afford it. So I didn't have any dental care until I was able to afford it just a few years back. And so I've had, over the last 3 years, I've had probably about 20 different procedures in order to get caught up now that I can, you know, afford that care. And my story is not unique whatsoever. Like the area I was growing up, we were actually one of the more well-off families. There are a lot of communities where they're, you know, not only insured, but there's, you know, just, you know, mistrust of the healthcare system, and that, you know, rightfully so for some reasons. But you know, ultimately, it's a pretty big problem. So I just want to share those.
Thanks so much for that. And I would love now to hear from Pamela, if you mind.
Hi, everybody. My name's Pamela Roeper, and I've been with NEOMED for over 6 years now. I'm an instructional designer with Academic Technology Services. Prior to coming to NEOMED, I taught English composition at the University of Akron for 8 years, a variety of positions, from adjunct to full-time, until they eliminated a lot of the full-time positions. I was part of those round of layoffs, came to NEOMED, love my job at NEOMED, but I'm a late bloomer. I went to college in my 30s. Prior to that, I was living in poverty, and had experiences with the healthcare system that I'll share with you later, throughout pregnancies. Particularly with my firstborn pregnancy, and how difficult and challenging that can be, and just how vulnerable women are in particular in the state of Ohio when it comes to pregnancies. and the lack of paternity care or maternity care. So, yeah.
Well, thank you all for those introductions as to where you're at now and how you got to where you're at now. And I'd love for us to move on now to sort of the meat of what we're here to do, which is to share some stories and some thoughts and experiences, really anything that you all with firsthand experience would find relevant to a discussion of this subject. So, you know, with the knowledge that you're speaking mostly to students of medicine, anything you feel you'd like to share or like to let people know about as something they may not have experienced themselves. So again, maybe alphabetical might just be easy. Dr. Barreiro, if you want to go ahead.
Yeah, sure. I mean, it's hard to follow what Dr. Palmer was doing, though I think his story is, again, not unique, but I would say, right, we're not a single story, and that's interesting when you view that from many different perspectives, the same exact aspect that occurs in so many of us. It's hard to identify who doesn't have and have insurance, and I think we take those things for granted over and over again. I think there's three approaches. One, first I would say, I love the organization or what you and everybody here are dedicated to do outside of or within the concept. I think advocacy from a physician standpoint is underutilized. I think the voice that we have is not spoken well. I think it's hard to navigate legislature, which you guys are actively doing. I think it takes a tremendous amount of commitment, and I don't want to underestimate that as someone who worked on the Minority Health Commission until last year, and then left because of term limits, not because I wanted to. So I think doing that, I think also what you need to do is continue to build within. And that's one of the things I hope that you get across, or at least one of the messages that I would have. If you haven't read a recent book, I loved it. It's called Uncaring. It is actually written by the previous CMO of Kaiser Permanente, and he talked about the healthcare system. I like the book in many different aspects, relatively easy read, but one of the things that he talked about is how the system is broken, how the system, and the system is broken on many different aspects because one, we as physicians, not necessarily people that are advocating here, have handed it all over to unqualified health professionals who look at it from a financial standpoint. And until we get reins on that, what you are dealing with and can we deal with on a regular basis, but hidden behind the scenes because our focus is on outcomes, which are poor, and not necessarily how people get there, right? That's the key. We focus on the end result, but not how people get there, is extremely, right, fragmented and difficult to maneuver. He also talks about how physicians are to blame, and I think that's really important. And again, we have this mightier than thou attitude that we forget that we are part of the problem because we don't see it as such. And because we are driven by RVUs, or what's called work requirements, and our salaries are based on that, he repeatedly says, and part of the problem that we have is that we look at it from that perspective. And as long as that's not being affected, now I'm all for making money, don't get me wrong, right? I make a good salary, etc. But I hope it never at the impact of what people need to get out of the healthcare system. And I do think this concept of nonprofit that hospitals hide behind is also very important and kind of a farce across the board. So I do love the book. I strongly encourage it. It seems right along the avenue of what you guys are doing, but I can't say for enough. But I do think you need to build within. And why I say build within for three purposes. Number one is, even today, I do not understand Medicare, Medicaid, right? And all its intricacies. Yeah, somewhere how you pronounce that appropriately, right? From A to B to C, what medications come under this, what's covered by that, et cetera, et cetera. So I think that's extremely important. Now you would say, how much do you need to know when you're trying to focus on the science, right? And right, the anatomy, the biochemistry in medical school, how much of that is actively important? And then I will tell you this, it's not taught in your clinical years, right? At all. Matter of fact, I remember an attending one time, my surgical attending, he says, right, he's filling out some paperwork and some chart, and I asked him, what is that about? He goes, you're not allowed to ask me till you're right, a resident, which he was filling out a billing sheet, right? And I kind of liked what he said, right? Because he wanted me to focus on things that are relatively scientific based, and there's a lot more to learn as a student and bedside care, et cetera. But at the same time, it's at the forefront of what we do on a regular basis. So I do think you need to build within and try to get people to believe that it is extremely important that's out there. My stories, I can have many, some personal and some not. I want to focus on things that I think are easily to miss. And that's number one is even patients with insurance. That's why I loved how you worded it, Emily, was are also in difficulty, right? The cost, I'm a pulmonary critical care. So the cost of inhaler, depending on your insurance, can be anywhere from $2, right, to $700 a canister. And no one can afford that, right? And you saw, and I know if you're politically active, you saw what the guy did with the EpiPen, right? And his arrogance on, right, TV to do that was, right? And what was interesting about that is how, right, the politicians had no power in order to change that because the laws aren't set up that way. So there's a lot of work to do. So when I developed the Pulmonary Research Center, 85% of the care, right, 85 was actually indigent. All right, so people that didn't have anybody that was C or a part of, pre-clinics, and the resources were that, and we filled up quickly, easily. Within a year, we were filled with patients who had no one to go to. And I tell you one thing that's really interesting. Now, why that may not seem like anything that's grand, and 15% were patients that came from my previous office. And this is two important points. Number one, as I came from private practice to join teaching, I was always a teacher, but I joined GME and faculty after a few years in private practice. It is exactly 6.5 miles from the hospital. 100% of those patients within a 6-mile radius had insurance, never had to worry about whether or not they were going to get their medication, always showed up. My no-show rate was 0.3%, right? They, right, made to all their appointments. They bitched on a regular basis, right? And it wasn't any problem, even, right? They got all their medications, they got all their tests done, and it was smooth sailing. You move 6 miles in one direction, north, right, to the hospital, and it was completely different. When we developed the center, the one thing that was very important that we had was a dedicated social worker, because it's hard enough to do the work that you have to do as a physician. Two parts to that. Number one is I probably put too much on social work to try to figure things out. And number two, the stories of what people were just trying to do on a daily basis, right? Between taking their medication, affording their medication, trying to find a ride to get in medication. So we wrote a grant, we got a bus where people can come to do that. It was filled up, but as soon as the grant was done, right, we couldn't get, right, people were right back to where they were. And this is the vicious cycle that when you're dealing with this on a regular basis, why physicians get so frustrated, right? It's a constant battle of trying to get the same exact simple things that, quote, people that you may know or that you live in every day simply can do, right? And that's get a ride, right? Not worry about whether or not they have to pay their X, Y, and Z versus their medication. The other part that we forget about, and this is something that I've seen over and over again, is even people with insurance can't afford some of the medications that they have. And I tell this story because it's personal. So about 5-6 years ago, my mother had bypass surgery. And I remember getting a call from the cardiologist. She was in the hospital, had an MI, she was in the ER. So I'm from Pittsburgh. So I grew up in Pittsburgh. So I drove to Pittsburgh to see what was going on. Yeah, right. And I walked in the room, right, and she's seeing the thoracic surgeon and scheduled her for bypass surgery. And I said, the usual pleasantries, how you doing, mom, blah, 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 everything will be okay, et cetera, et cetera. And then it got to the thing where I wanted to look through her medical records to see what the hell was going on. and found out that her hemoglobin A1C was 11, right? And her cholesterol was 325 and her triglycerides were really high. And which prompted the question, Mom, what's going on with your diabetes and your high blood pressure and your medications? And under my nose, and someone who makes a good living, is they couldn't afford it, right? So my parents, lower middle class America, right, who live in McKeesport, PA, who are on a fixed salary, under my nose without me knowing, or and I should know, quote, know better, right? Because how many patients do you think I see on a regular basis? So even when it's right underneath you, you can't, it's hard to recognize. Because as far as I'm concerned, my parents were fine. And so I think, how do you approach this, right, when all the other things you have to take care of? And there are lots of checks, right, that doctors have to do on a regular visit, right? Because some administrators telling you have to do it because reimbursement from that system comes from that. And then how do you find to do that? There was a study said that a primary care physician just doing preventative medicine itself would take 2.5 hours per visit just to finish that alone. So how do you have time taking care of anything else? So I think that the degradation of the fragmentation of healthcare concerns me. In other words, hospitalists are running the hospital, right? They're not invested in primary care. They're not invested in the patient on the outpatient setting. Getting them in and getting them out is important. Whether they get insurance or not insurance, that's the bill that comes to them and not to the hospitalist, right? And if you're not going in internal medicine or into a primary care practice, how do you then follow up on that and get to all the information? Second thing is patients are prideful, right? Specifically, and all across the board. They won't share stuff with you if you don't know until it's at the last room. I will tell you, lots of health, diseases of health, anxiety, complications become calmer when people get health care. So the AHA, the Obamacare was very important. And the hospital, and my practice, when I said was 85% indigent, currently is about only about 35%. Now, what happened? It wasn't that everybody got wealthy, right? Is that we enrolled people in the health exchange. That was good and bad. This is the things, the subtle things that you know. When people got health insurance, right, they also had to pay copays. A $20 to $50 copay to see a specialist is more than you can imagine. Honestly, I get pissed off when I have to pay $50 for my endocrinologist check, right? And I can afford it. I don't know why I'm pissed off about it, but I am, right? I'm like, I don't know. I know that guy and I trained him. I know he's not that good, but I don't know, $50. So anyhow, those are the things, those are the subtleties that you're not aware of. And it came to the point where the administrators, we found out, were telling our front office staff who are not, again, I work for the hospital, right? So I don't own any of my nurses. I'm not in private practice. You can, right, whatever you say kind of goes because you're running the ship. They're employed. And the administrators, we found out, were telling the front office staff if they can't pay their copay, the doctor can't see them. And I said, that doesn't work this way. We will see people regardless of whether or not they can pay or not pay. It doesn't matter to me. You know what I mean? So these are little things, right, that just occur in the inner makings of what you do on a regular basis. So I think you have to, what I'm trying to say through this all is, one, is even at my years of doing this, it's complex and I can't understand it. I try to understand it. Number two is have the discussion with patients, however that you can approach that. The concept of the social history is being lost because it's added by someone else. And it's the social determinants of health are 70% of healthcare problems, then we need to approach that, not just their chief complaint. And number three is, there's a lot of work to be done to try to figure out how to best approach it. There are things of which are supportive that a lot of physicians don't know on a regular basis, right? Such as you can get a humidifier if you have asthma. You can get, you can write a letter to make sure their electricity, doesn't mean they still don't have to pay, right? But to keep their electricity on. These are subtle things that you're not taught, that you learn, but you have to be available to be receptive to learn that. And I think those things are really important. And I'll stop there and then ask questions.
Thank you so much. It's a lot of great insight and stories, and I'm sure this is something that you could probably talk about all day, as many of us feel, I'm sure. We'll go ahead though to Aaron, if you prefer, if you've got some stuff you'd like to share with us.
I'll keep it short just because of time, and I shared some of my stories, but I completely agree. Social determinants of health, we kind of, pass by it really quickly, but that really determines the care that, when patients walk out their door or walk out your office, they're going home, they're going back to that environment, they're going back to that food desert. They may not even follow up with you. And that ultimately determines their health. The legislation and Medicare and Medicaid is so fragmented. It is mind blowing. So I applied, I do a lot of community work, and I was trying to apply for a White House fellowship. But in order to apply that, you have to come up with a policy. I was like, well, I'll just, come up with something really low hanging fruit. I'll just make, dental care free for everybody and try to figure out how it would work. Man, I worked for like 2 months on that. I still couldn't figure it out. It's very, and I don't want to kind of go into detail, but it's very complex. But I don't think that two different people living in the same city should receive different care. The life expectancy here in the Gold Coast should not be 20 years higher than the one on the west side of Chicago. That is like ridiculous, but it's a fact. So I think this is very important. I don't have all the answers, but I'd love to talk about it. So sorry, I didn't want to take too much time.
That's totally fine. Thank you for sharing. And it's interesting to hear about the way that physicians can touch the advocacy efforts. And that's something we'll hopefully chat about a little bit more, maybe during the Q&A, because I think you all will have some things to share on that front as well, since it's a new thing for a lot of us. But anyway, we can move on then if you'd like to. Pamela, I'd love to hear from you and your story.
So yeah, my story is a little bit older. It happened in the 80s. I was living with my dad and my stepmom, middle class, solid middle class, although I didn't know at the time that's what it was. I lived in a rural area at that time, but outside of the suburban area. And I became pregnant. I was still in high school, and my stepmother asked me to leave the house. And so I took my $268 I was making a month, and I got an apartment in probably the worst area in town that I could find, because it was also the cheapest. So lead paint everywhere, just open plumbing, disastrous. It's funny, Aaron was talking about taking a bath all the time. These apartments were so small, they only had showers. And so you couldn't take a bath. There was only a stand-up shower. The bathrooms were so small. They were literally cinder block tenements. I've never seen anything like them since, although my dad said that during World War II, there was a lot of housing that was built like this. And this apartment complex had been former World War II housing. It should have been torn down, and it never was. Didn't qualify for subsidized housing. And so I had to pay that full $215 in rent. When I moved out, I went to try to get health care or Medicaid, and not understanding the system or how it worked. Back then you had, I don't know if you do it online now, but none of it was online then. There was no internet. So you had to go in, you had to take a day off. So I had to skip a day of school, and I had to go in and wait and pick a number and see a caseworker and fill out a lot of paperwork. And I was denied. I was told because I was in high school, it was assumed that I would be on my parents, even though I was estranged from them at the time. And I did not have money for copays or deductibles. So I just didn't see a doctor. There was no clinics in town. I didn't live in an urban area or a rural area. I lived in a suburban area where there just weren't those type of healthcare clinics. So there was no free care for anyone. I was told that I could quit school. I could quit high school and I would qualify. But I was so close to graduation, I didn't want to do that. So I just thought, I'll just take care of myself. So that's what I did. I later went back about 2 months before my due date because I didn't know how I was going to deliver the baby. And I reapplied and I was granted Medicaid. Of course, when I was paired up with a doctor, there weren't a lot of doctors in my town that took Medicaid. So that was a problem too. There was one doctor that was taking it. He was an independent general practitioner. So he wasn't a specialist or anything. But he was a good doctor. He was very old school though. So there was a very paternal nature to the way he practiced. Meaning, you know, I would kind of get patted on the head and talked down to a lot. I was very fortunate that I had my daughter with few complications. There was a little bit of some complications and he handled it. She didn't have to be in a NICU or anything. I was very fortunate in that respect. Not all women are when they don't have paternal health care, when they don't have maternal health care or prenatal health care. I was very fortunate and I realized that. It didn't get any better from there. Even after I had my daughter, it was difficult to get in to see, to have appointments with the Medicaid. Eventually I started making too much money and I couldn't have Medicaid anymore. Back then, the limits for what you could earn were very, very low. Like they were very high. Like you could earn minimum wage and you wouldn't qualify. But if you had a minimum wage job, chances are you did not have health care that was provided by your employer. That just was unheard of back then. I didn't know very many people who had it. You just didn't go to the doctor, and that's what I did. And I just didn't go to a doctor, and my daughter didn't go to a doctor. And what has happened is, I think, you know, Aaron alluded to it when he talked about having dental bills now that he has to pay from not seeing a dentist for so long. It's what happens when you don't see a doctor for a long time. I have a lot of persistent healthcare issues now that I have paid the price for because of being so poor and unhealthy prior to where I am now. And my daughter as well too. And I just like to add to dental care and mental health care are health care. They should always be included in health care. I get so frustrated when I hear people separate those things because they can't, because I've known people when I was living in poverty, I knew many people who actually got impacted teeth, who had infections, one of whom got a very bad blood infection from their impacted tooth and was in the ICU for many days because they were so sick from this tooth. So you cannot separate those things. Mental health care, dental care, they're all part of health care. Also, I think if I could say anything to you upcoming doctors is when you see someone who you think maybe their medical literacy is not up to par, be gentle, be kind, treat them with dignity. I think one of the reasons that I stayed away from doctors for so long is because I didn't have established relationships with anyone. And I've always felt like I was belittled or that I was talked down to or I was judged. And that kept me away. I'm very fortunate now. I have a wonderful general practitioner who's always trying to push me off on specialists for things, but she's my primary doctor. She's actually a NEOMED graduate, and I just adore her and hope she never, ever retires because I don't know what I'll do. But yeah, I think that just be kind and patient with people. I think that's the biggest thing that I can pass on. I think also to that idea of the fact that we kind of created more problems in some respect with when we went to the healthcare exchange. I know a lot of people who have had to purchase health insurance off of the exchange, and a lot of times it's just terrible coverage. It's not going to cover a lot. It's catastrophic insurance. It's for if something really huge happens, and it'll maybe pay some of that. But yeah.
Yeah, I think there's a common conception that if you're on Medicaid, you're just uneducated and there, I think some is a professional nihilism that, well, you made bad choices, not me, and thus you just, whatever I can give you, you should just be appreciative of. And I do think that for the majority of patients are aware of whether they have and not have insurance and their ability to ask questions or be vocal about the care that they're being provided. And again, if people don't ask, if we don't ask them, because of time constraints that we have, and you think, oh, I'd never do that, you're full, you're just fooling yourself. perpetuates the continued problem, no doubt about it. And it's difficult. I'm not sitting on a pedestal. I have effed up every encounter I possibly have been in, and I've done everything wrong that every book says you shouldn't have done. I pretty much have probably done it, right? It's the nature of it, right? But you hope that you can self-reflect and get back to some commonality of what we can do. You know?
Yeah, it's a great point, and it's a great thing to consider and to be mindful of for our future practice for those of us that will end up working in healthcare in one regard or another. So I think, we've had a chance to hear some stories and some thoughts, and we can maybe for the last 20-ish minutes or so do a little bit of Q&A. I'm going to start with a couple questions that we have just generally, and then, as I said before, anybody who's listening in, feel free to put a question in the chat, send it to me or to Sam directly. Make a little list of those and get through what we can get through at the time. So I guess to start, again, thank you all. I can't thank you enough for being willing to come in and talk about this stuff, especially because it can be a difficult thing, an emotional thing, particularly having a personal experience with it. And I know that there are elements of this discussion that can be hard to talk about just because it's a political issue. It's a thing that has, effects in the political, economic realm. It's a thing that people can disagree about somewhat vehemently, vitriolically, in a way that we don't disagree about normal everyday considerations. So I guess maybe a question for is, what would you recommend maybe for a student or somebody who's going to work in healthcare who cares about this issue, but who maybe doesn't see themselves as political or doesn't see themselves as someone with a history of advocacy? If you have any recommendations as a physician or as a patient, someone who's experienced this, what would you say maybe to encourage that sort of work with somebody who is cares about the issue, but is a little nervous about sort of the political implications of taking a position in this debate?
Yeah, I'll start off on that one. First of all, I think, there are levels of advocacy, right? And sometimes it's the local one, the face-to-face one, that is far more important than what happens on a national level, right? And so that interaction with that patient will be more. I mentioned, the difference between private practice and the 6 miles. Every one of the patients that came in to see me, even with my indigent population, was still only 13%. In other words, they were appreciative that someone would actually take the time to do that, right? And listen to them and see them. And so the advocacy occurs there first, right? When you learn about the individual and you gain, right, then your civical duty, right, will expand dramatically. Number 2 is, you think you know advocacy, but you don't even understand the system. I've been doing it 20 years. I'm still figuring out the system, right? Not only the political system, right, within the hospital, and in academics, it's even higher, right? Because everybody is fighting for, right, ground, silos, space, etc. So the concept is right, the best part, this is not my quote, but Mandela's statement. He says his dad, right, what he learned from his dad is to listen first. And what I mean by that is, right, we always have an agenda we're going in. So advocacy starts with that. And he said his dad would go, right, who was a preacher, would go to different tribes, right, throughout his continent, and he would be the last person to speak because it was very important that everybody had a voice. So merely just listening, and it's coming from someone that we would all revere to be a pretty big leader, I think that's something that's extremely helpful. So I think number 1 is, don't panic, right? What you are passionate about now may change, or within the realm of, right, insurance, non-insurance, may, right, change within that. And so, but you got to develop the skills of learning. You got to develop the skills of listening first. Number 3 is, you think you know the system, but the system's bigger than you can imagine, and I'm still learning it, and how to work through it well takes time, effort, mentorship, those kind of things. So I think start at the level, right? Learn empathy, right? Or develop your skills of empathy, right? Because that will change everything. And your perception of what you're dealing with and the levels of what you're dealing with will change dramatically. So that's the one thing I would say. right? Take your time, listen, develop empathy.
Any other? Oh, go ahead. I was going to say, any
I
other
don't know,
panelists want to jump
if
in?
I could say that any better. I mean, I can echo a lot of what he said. It's just, I mean, it's being invested in your patient, learning about them. And then once you learn about their story or know, you know, then you just treat them. You do what's best for them, ultimately, whether it's what's in their best interest for, you know, from insurance or trying to figure those sort of things out. You just advocate for your patient. In neurosurgery, we have, you know, sometimes we have patients who require surgeries to remove a seizure focus. And often those patients will be in the hospital for a week. So they get put through the neuropsych testing. We do, you know, we do all of this. We have them meet with therapists and that sort of thing. But people who don't have the reasons for those, actually, I mean, a lot of those things, a lot of those tests, they have to go for PET scans, all kinds of stuff that wouldn't be feasible for a patient who's underinsured or doesn't have the, you know, socioeconomic background. So that type of stuff gets brought up when we're in the committee, you know, talking about who we're going to operate on. And I think that, you know, those social determinants of health should never really affect the choice of whether somebody goes to the OR or not. If they absolutely need it. So it's just advocating on some of those committees and just, you know, treating your patient. But I can't say it any better than he did.
I think from a patient standpoint, I think the one thing that I would suggest, and this comes up a lot when I volunteer on the poverty simulation that we do at NEOMED. We just got done with, I think, some of the farm students and some outside groups came in as well too. And that is to familiarize yourself with social services in the area that you're practicing. Have a couple pamphlets in your office. You know where some of those numbers are, just have them somewhere. So if somebody does come into your office and they see that number, maybe it's, you know, a mental health, a community mental health services in the area that offers low income or sliding scale fees, those type of things. Just be familiar with what's available because that navigating that system in itself, I'm amazed anybody can do it, honestly. And I was an 18-year-old trying to negotiate that. I can't imagine someone who's struggling with a health issue trying to navigate that system because it's very difficult. They do not make it easy. People who are poor, they're pretty savvy. They're some of the smartest people you will ever meet because they survive. And I tell you, you got to give them a lot of kudos for that. But the system of navigating, getting assistance, getting housing vouchers and getting Medicaid or Medicare even, it's very difficult.
Yeah, I'd like to just add on that, Pam. I love that part of it. I mean, the other part too, it's really important. There's nothing that's more frustrating to me as attending when I see residents, well, what are you going to do about that? And they'll say, we'll just consult social services or we'll just consult social work. And the answer is that's probably fine, right? Because you only have an infinite amount of time and there's lots of things that need to be done. But what do you think they're going to offer that? And what do you know about it, right? That's the part that I think was really important, right? And I'm not, I get it, right? I mean, at the same time, I get it, right? There's a lot of other things you have to do and you're making life decisions on what medication someone may need to have, whether or not to do brain surgery or not, right? That's pretty big stuff, right? And so, but there's aspects of what it means, right? To put in that consult, right? And why I say that word, how I put that very importantly is it's okay to consult social work, but it doesn't mean you as a physician doesn't have to know what's in the realm of that, right? And take the time to learn more about it, right? Because take it now, because I tell my residents all the time, you think you're busy now? Yeah, it doesn't get any easier, right? The levels of complexities does change. And so I think I like that part and wanted to extend on that a great deal.
That's a great point. And it is very important for us to, I'm glad everybody here is at least taking this amount of time early in their training to try to learn something about these experiences. And it's something that none of us will escape from being touched by, I think, no matter what
And
manner
remain
of practice?
patient. And I can't say that enough, remain patient, right? The answer is that all students come out with this altruistic idea, right, about, right, to save the world. And I love it. And right, there's studies that show that it takes about 6 weeks for you to lose that, right? It's not long in your clinical years, but you don't have to, right? You don't have to. It's how you choose to do it. And it's not that there won't be hard times and easy times and everything else in between, but just patience, right? And those skills. It's really important.
We've got, I just want to make sure we get to the questions people are asking. We've got one question for Pamela. Max would like to know, how did you come to find stable insurance, and what was that experience like for you, if you're comfortable to share?
So the only time that I've had or been comfortable and had insurance is there was a time where I was married. So I had insurance through my husband's insurance. It wasn't great, but it did allow me to go see the doctor when we had the copays. I did have 2 more children, and it paid for some of that. I had difficult deliveries with those 2, so it was very expensive. So I was very fortunate at that time that I did have insurance. But there were times that as an adult, that I did not have insurance. And as an adjunct, when you're teaching, you don't have insurance. I was very fortunate that after my divorce, I was able to find full-time employment that had insurance. I still have to be very cautious because I am single. So, I'm living on one income. I have probably over 200 a month in medications that most of those I will be on for the rest of my life. So when if it's a year that I'm going to have a surgery or something, it's going to be expensive and I'm going to have to save for that, or I'm going to have to put it on a card and pay high interest to pay it back. I mean, it's just, I work at NEOMED, but I tell people, doesn't mean my healthcare is free,
Yeah.
I do try to get therapy for free from some of the people in Department of Psychiatry, but.
I mean, you guys are too young for this, but I think, most of the time patients insurance were due to large corporations. If you worked for GM, if you were part of, right, National Health Network, PPG, et cetera, your insurance came because your employer paid for it. And it wasn't bad. But now, right, due to the economics, right, more and more people are small business owners. They can't afford any of it. And even people that you look are fine. Like even, one of the instructors at the gym, she's all hunched over. Well, what's right? She says, my back hurts. I said, well, why don't you go see somebody? She goes, I can't afford it. I mean, I was like, oh shit. Yeah, you forget those simple things that you see every day that right now are affecting people on a regular basis. And it's difficult. And listen, I work for the hospital and our insurance is awful. Right. right. And I work for the healthcare system. I was like, what? Right. It's right. It was better if you pay for yourself or with the other corporation or when I was in private practice, right? But it's something, right? And again, given the fact that the #1 cause of bankruptcy in the United States is healthcare bills, right? It's a huge problem. And I go back to saying the majority of people are proud. They would, right? They would rather pay a small fee. It's the concept that, the other part, here's my point. Physicians in itself and all you want to help and do everything. And God bless. I hope that's why we're doing what we do. The truth of the matter is why the discussions are so important and to get know your patient is because not everyone wants a handout. Okay. That's really, really important. It's why, right? The senator was never going to win because she just wanted to tax the rich. The answer is American people want to earn an honest living and work. I know my Latino groups, they would rather pay $3 a month than ever take anything free. It's something, there's pride with that. So we think just giving it to them free or I'll just do all this stuff for them. The answer is you have to figure out where people's levels are, and it does change. And so think about that. It's easy just to say, well, we can do X, Y, and Z. And again, that's good. And they'll take some assistance, but take it a step further if you can.
Yeah, one of the main questions that was been coming up in discussion mostly is just if universal healthcare were to become a thing, since that's what the organization here kind of stands for and what we've been motivated by to be together as a group in the first place, what would that mean for you, and how do you see that potentially changing your viewpoints on these issues and what you think would happen or how that would impact you in the future?
Want me to go last or first? Because I seem
It doesn't matter. We would care to hear from a patient perspective or a physician perspective on the issue.
Oh, I'll give you my perspective. I'm a big mouth, that's for sure. But nonetheless, I honestly, here's
Great.
some truth to this. And I love the question, right? And the answer is, I'm not sure if it'll change my perspective. Because what I mean by that is that as a subspecialist, my view may be somewhat narrowed on what I'm treating or not treating. And I think when we think about universal healthcare, what exactly do you mean by universal? Everybody, what they consider universal may be completely different. For me, I think universal healthcare is the ability to get, if you're asking me, regular medications in a cost-effective way. Number two is preventative care. What comes outside of that, I think, also requires some personal responsibility. And that's that's the line between how we educate. But we don't. As physicians, rarely are there any education that occurs in that office. It is mainly dispensing medications and checklists. And so that's why the paradigm's not going to be fixed. So despite universal health care, right, the answer is that most people want to know, as the physician side, and this was talked about in many different books, is whether or not it's going to affect my salary. And that's not, I mean, believe me, we could say we're all altruistic about X, Y, and Z, but you start to take something out of someone's pocket, they uprise faster than you could imagine, right? And as long as that's not affected, that's probably okay. So I'm all for it. And what it exactly means, I mean, it's nice on the political stage, but the answer is, what I mean is that I hope that I treat everybody relatively effectively, probably relatively the same, which probably is poorly, but nonetheless, right? But, do the best that I can. So I'm not sure it's going to change my paradigm, but I do think people deserve effective medications, right? That's cost effective. For me, that's universal, and preventative care, right? Because if we can do that, I think we'll have far better of dealing with all the other medical problems along the way, right? But we didn't talk about things that are outside the healthcare field, and that's what we eat, right? We, as one said, we have an unhealthy nation, right? We spend the most amount of money and have the poorest outcomes for the amount we spend. And so will universal healthcare mean preventative care and routine medications? I think that will reduce that burden dramatically. So I go through those two things when I'm asked that. There's probably more out there, but those are the two things that stand out to me when I practice every day that infuriate me. I was like, you would be better, you would not X, Y, and Z occur if those things happened.
From a patient standpoint, I think universal healthcare will be awesome. I think that, and like, I mean, yeah, like political beliefs and that sort of thing. I think regardless of whatever you need, you should be able just to go up and get it. I don't think that healthcare, I think that's just a right that we should be able to provide to people. I don't have any solutions for it. I don't know how to go about it, but I think that everybody should have the same care regardless of what they need. I don't know how it will affect. So obviously neurosurgeons, they like all care about their salary. I don't know how it would affect my day-to-day, because those things from a day-to-day standpoint shouldn't be, considered, honestly, when it comes to patient care. So hopefully that won't change that. But from a salary standpoint to how, who's paying what and how that's getting paid, and the insurance companies and the pharmacy, I think it just needs to be a complete healthcare reform, and just kind of a rewrite everything, rather than kind of putting, little stops on all these little holes and trying to figure out, everything. I think this needs to be a complete healthcare reform. I don't know how to go about that or what that looks like, but
yeah, I think the first thing that we do is you put it in, you put it in small things. When you make huge changes, people get pissed off, right? So you nudge them along the way, right? So, you do a little bit here, you do a little bit more, and then people see that it actually works, right? And the answer is, we know it works. Look at other countries. It works, right? Right. But, you know, it's America. We're elitists, right? We're X, Y, and Z and all those things that come in between that, right? And God forbid that someone gets something that we don't have. And right, I worked hard for this and all this other stuff in between that. And I get it, right? That's the great part about diversity and right, listening and all the things in between there. So a little bit along the way, and I think we'll get there. But again, that's why I said patience is really important. Right? Because it's easy just to say, do it all, but the answer is it's not, right? And so there have been huge changes, and that's why your program is really important, right? But how you have to grow within, right? Because a voice of 12 is not as good as a voice of 20, all right? And a voice of 20 is not as good as a voice of 50, right? And all the little things that occur in between there. Yeah.
And I just have to add real quick, as from a patient perspective, I would be thrilled with Medicare for all. However, with some, I mean, I'm not going to tell, I do have some concerns, of course, if we were to roll out something like that right away. As a patient, I would be worried about wait times. It takes me over a month to get into my general practitioner now because she's so busy. I see a lot of specialists, so I would be concerned that maybe there would be some entity that would be judging whether or not I could see those specialists anymore, or how many times a year I could see those specialists, or lab tests, or anything else that I needed to have done that I'm able to have done now for the most part. I still sometimes have to battle the insurance company, but I would be concerned that some of those things would be limited, and they probably would. But I'll tell you, if it meant somebody else having healthcare, I would make those sacrifices. I would. And I would like to think that most people would.
I'd hope so too, but you're right. If everybody wants the best of the best, right? So when you come in, you have chest pain, when you simply can get an EKG and a stress test, because that's what the evidence shows. But if it's universal and they're driving it and they said, no, I want a heart cath, we're not gonna have enough people to do it, right? If everybody got an MRI because they had a headache, you're going to be really busy, Dr. Palmer, right? Because they're going to find stuff that you don't necessarily want. What do you have to do about it? But again, even in Canada, they wait months in order to get their knee surgery. And it doesn't eliminate this one thing that's universal in the United States, and that's disparities, right? Despite that all, right? People of color, people of disadvantaged backgrounds still, even when they get in the system and even have the test done, it's not interpreted the same way. We have to grow from within. We have to have honest discussions, right? And not think that one thing about students that come out of the board is they make statements which are appropriate, but yet at the same time, right, they don't have the depth of X, Y, and Z, and you have to appreciate that. It doesn't mean you don't have a voice, right? It doesn't mean you shouldn't speak up, but how you do it is really important, right? Right? Because, yeah, because all those other things, right? Perspectives that you don't know, right? In the years of what people have gone through, right? In order to get where they're at. So just remember that.
Thank you all for giving your thoughts on that and for all of your time this evening. I know we're right just about hitting our limit here, so I know some people might have to go, and I want to respect your time as panelists. Thank you so much for joining us. And if any of you are interested or willing, if you'd like to, feel free to put your email in the chat, and maybe if some of the participants here have questions or anything else directly, they could reach out to you. Don't feel like you have to do that if you would prefer not to, but just so that people have the option, since some of the questions probably didn't get to be reached in this short time we have. But thank you all for attending. A quick shout out for what we're doing with SNaHP right now. This is 2 days before a discussion, or I guess a session we'll be having at the Kent City Council, trying to pass a resolution in support of Medicare for all. It would mean a lot if any students or anybody who's in the area would like to come out and support us or give some testimony on that. If you're interested, we will be maybe sending an email the next day or two with some information on that. So we'd love to see you guys there. We know you're all busy, but thank you so much for making time to attend this tonight and for your thoughts and care towards this really, really important issue for all of us.
Good luck, everybody.
Awesome. Thanks for having us. This was great.
You.
Thank you.